Sorry for the delay. So first thing is, whenever you have any complications, whenever you have any complications or for whatever reason, if you want to come off ECMO, as I told you when I was discussing trial of, any reasons you want to come off ECMO, you have to put the clamp on the return line, okay, or the arterial line. Always first when you want to come off, always put a clamp on the return line, and when you want to go on ECMO, release the return line or arterial line the last, okay. That's the dictum you should always remember. So when you want to come off, put the clamp on the return line or arterial line, and when you go on ECMO, release the arterial line in the last, okay. The reason, as I told you, is it is a centrifugal pump, okay. So it is a non-occlusive pump. So if you don't put the clamp on the arterial line, there will be a reverse flow. So always remember that you have to put the clamp on the return line when you want to come off from the centrifugal pump, and when you go on the ECMO, you release the return line in the last. So that steps you need to follow, okay. But it is exactly opposite for the roller pump. If you, by chance you are using roller pump, never put the clamp on the return line on the roller pump when the roller pump is moving, otherwise it will can have a rupture of the tube, okay. ये चल नहीं रहा तेरा. So exactly reverse is for the roller pump, okay. Now first thing which we are going to discuss is the air in the circuits, okay. Now what are the sources or from where the air can enter the circuit? The sources of air are from where it can enter. First is from the pre-pump lines. Any in the pre-pump line, because as I know, pre-pump line, it is a negative pressure line. So any disconnection in the pre-pump line, any crack in the pre-pump line will lead to, you have to have, okay. So any disconnection in the pre-pump line will give rise to air getting sucked in the oxygenator or in the side, okay. That is the one source. Second source, when there are too much of negative pressures, okay. If your pre-pump pressures becomes more than -200, it causes cavitation and the air is generated inside the circuit by itself. So that can be another source of air in the circuit, okay. Third is, there is too much of positive pressure in the gas phase line. See, in the gas phase line, the oxygen or the air is moving in the gas phase line. If that gas phase line exhaust is blocked, okay, what will happen? The pressure will be built up and the gas phase will rupture, and that will lead us to air in the circuit, okay. Then what are other sources from where the air can enter? Yes? All connectors. That is on pre-pump line, all connectors. Then? Patient how? Central line. Okay. See, this patient has central line. So if there is a air goes from the central line, it is going to go to RA, and from the RA it is going to get sucked up because your cannula is in the somewhere near the IVC. And if it is a VA ECMO, your cannula is itself in the RA. So then that is a chance. Okay, fine. So that is it can come from the central line. Next. Now we are very close. Central line. Then when you are switching over from VV or VA to VAV or VV to VVE. So when you are putting additional central line or additional jugular line, when you want to switch over to VAV, okay, patient is already on ECMO, okay. Your cannula, suppose patient is on VA ECMO, now you have to switch over to VAV. So you want to put additional jugular line, okay, to put a return cannula. So when you take a puncture, you aspirate, you disconnect the syringe from the needle, ECMO pump is running, it will suck the air from the needle. Okay, so that is another source. So when you are switching over from VA to VAV, you have to be mindful that somebody should clamp or somebody should stop the ECMO for 2 or 4 seconds till the time you put the guide wire inside. Once the guide wire is inside, then the risk of air getting sucked is less. But when you disconnect the syringe from the needle, that is the time the air can get sucked in. So you have to be mindful about that. Okay. So that is another source of air that can go in. Okay. Now how will you manage this air in the circuit? See, this air in the circuit complication has come down drastically. The risk is less than 10%. Sorry, less than 2% rather. So that is an important part. If it can go in the venous side, okay, or it can go to the arterial end, okay, or it can go to the patient. If it is in venous end, there are two places where the air gets trapped. One is in the pump and second is in the oxygenator. So it can get trapped in the pump as well as in the oxygenator. So if the air enters on the venous side, you are not much worried unless it is a massive air. If it is a massive air, then it can stop the pump completely. If it is a small air, you are not worried because it gets trapped in the pump and then it gets trapped in the oxygenator, so it won't go to the patient. Okay. So there are two safety mechanisms in the venous side. Okay. If it is in the arterial side, that is after the oxygenator, then you had it. See, by the time you realize it and you stop it, air is already gone inside. So because your flow is 3 liters per minute, your flow is 4 liters per minute. So by the time you realize and you try to put the clamp, yes, theoretically, answer is if you see air in the circuit, you just immediately put the clamp on the arterial line or arterial cannula. Okay, that's the theoretical answer. But practically, it is going to be very difficult. By the time you take the clamp on, the air is already gone inside. Unless it's a massive air, so some air goes inside, but you can prevent further more air to go inside. That is what maximum you can do it. Okay. If it goes to the patient, you actually can't do it. You can do hyperbaric therapy and you can give a a head low position so the air does not go to the brain. So that is what some preventive steps you can take it, but otherwise nothing much that you can do it. Okay. So we'll show you how the de-airing can be done and what happens when the So now what we are just pushing the air in the circuit and show you. इसको focus करना. Pump यहाँ पे. Very there. So I'm just pushing 10 ml of air in the circuit. Just look at the pump. Look at the return line. Could you see any of the air going in the return line out of the pump? All 10 ml of air which has gone inside, you can see it here on the can you see here? Pump speed come करना. Can you see it here? You see all this air is accumulated here. Okay, and it comes up when I stop the pump. So the pump acts as a trap for the air to go. So air doesn't usually go, okay, unless it is massive air. Even 10 ml of air didn't go there. Okay, fine. Now suppose this is air in the pump. How will you remove this air? Okay, it's very simple. What you need to do is, whichever the place the nearby is, connect. Nearby pigtail, wherever it is, continue रखना. Okay, you connect the syringe to the nearby pigtail. Okay, then what you need to do is you have to either, depending on the patient's stability, if patient is stable and you can wait for a patient can be taken off ECMO for say for 30 seconds, 10 seconds, 20 seconds. Okay, you can completely stop the flow. Okay, so when you are stopping the flow, again put the clamp in return line. So when I say return line, it means anything after the pump. See, when I put the clamp here, the air comes up, isn't it? So I take the air like this and I aspirate it. Now if patient is stable, I can aspirate the entire air at one glance. Okay. And then increase RPM. And I can release the clamp. If patient is not stable, this is what the ELSO says. Okay, if patient is not stable, what we usually do is, when the 10 ml of blood is not, air has not gone inside, if I remove 5 ml of blood, the rest of the 5 ml of air is not going to go inside again, isn't it? It's going to get trapped here. So if patient is not stable and you are taking long time to remove the air, it's always better to divide into few steps. Okay, so you take the air out whatever you can, restart the pump, because definitely the quantity of the air is going to be less now. Okay, so it won't cross the pump. At the same time, even if it's crossed the pump, it's going to be an oxygen which is going to trap it. Okay, so it is going to get trapped there. So you are not worried about that part. Okay, so you can do it in 2 or 3 steps, and you can remove the air from the pump like this. If it goes to oxygenator, okay, then you don't require to do much, because it will get trapped in the oxygenator. It will come up here somewhere in the oxygenator upsides. Okay, so from the pigtail which you have, this is the pigtail line. In all oxygenator you have pigtail line for de-airing. So from there you can aspirate the air. So you don't require to even stop the pump, because you can directly aspirate from the pigtail line if it goes to the oxygenator. Okay, so this is the way you can. This is the way you can remove the air from the circuit. So from the pump, I'll show you how to do it. Slides. Okay. And from the arterial end, as I told you, if there's an air, it's going to be difficult. First of all, you put a clamp, and if you see the air is there, and if you have bridge, take the air into the bridge. You can close the bridge and you can start circulation immediately. So you will not waste much of your time. Okay, if it is in the bridge. Okay. Again, whenever you are going to come off ECMO, you have to remember that you have to go on the ventilator, because on an emergency ventilator setting, you have to go up on the high ventilator settings till the time the ECMO is going to remain off. Okay. If it goes enter the patients, again that's going to be a standard management of how you have to manage air in the center. Always give a head low position so that air does not go to the brain and coronaries, it goes to the periphery, and then you are less worried about it. If it goes to the coronaries or brain, you have to think about hyperbaric therapy, and patient can develop hypotension, so you have to give inotropes and everything. The next is what I'm going to discuss, power failure. Now this is the most important thing that all of you are going to do it tomorrow as a team during the session, and at the end of the session, somewhere around this time, you will be doing by individually, and you will be assessed individually. So this power failure is most important. Okay, each and every machine has got a battery backup. Okay, and this battery backup, as I told you, can be 45 minutes to 2 hours, or 1.5 hours to 2 hours. Okay, again depends upon how fresh the new battery is, how old battery is, how much your RPM is required, depends on that. Suppose everything stops. Okay, machine stops suddenly. What are the things we are going to do it? Okay, now these steps you should always have to have in your mind set well. Okay, first thing is, suppose machine stops. Machine stop. So upon machine stops suddenly, first always put the clamp in the return line. That's the first step. When I say return line, it can be anywhere in the return line. After the pump, it can be anywhere. Okay. Then take the pump out. Now see, remember, each pump, as I told you, is a locking mechanism. So you should know the locking mechanism of your pump. Take the pump out. Okay. Call for the help. Ask somebody to help you. This is going to be an emergency situation. It has occurred suddenly. So call for the help. Put the pump on the hand crank, and yes. Can you hear that voice? That is important. So it got locked. Then you have to increase the RPM. It is going to move in one direction. It will not going to move in the other direction. So increase the RPM. Take the RPM to 1500 and then release the clamp. Okay? And maintain the same RPM what it was before. So you should know the RPM what it was going on. So you maintain the same RPM. So saturation is going to be maintained. You will not able to see the flow because the monitor is off. Okay. So you have to maintain the same RPM, monitor the saturation, vitals, that is important, and continue till the time some help comes and you get the problem gets rectified. Is this clear? Okay. It looks very simple, isn't it? The problem comes is, always remember, reading nahi dikha. Okay. Can you see the reading here? Can you see the lights there? And you have to maintain the same speed. Okay, that is what the important is. See, the management of the problems here, it feels very simple, isn't it? Okay, I want one of the volunteer to come and do it. Any volunteer would like to come and do it? Okay, fine. इसको यहाँ से डिस्कनेक्ट करते हैं. Yeah. Okay. इसको यहाँ पे ले लो. वहाँ पे रख दे. Yes. Now this machine suddenly stops. Okay, it's running now. Come on this side. Yeah. Huh? Yeah, the machine is stopped suddenly now. So you have to take the person on hand crank. Okay. See, it's what it looks simple is not that simple, isn't it? Yeah. Yes. Turn on this side so that everybody can see. Yeah, turn on this side. Okay. Okay. Fine. Well done. If I ask you to continue this for 5 minutes, will you able to? It's difficult. And that is what exactly it is. See, your management of complications starts when you initiate ECMO. This is a proper planning that is essential. When I did it very simply. The reason is not that because I am an expert. No. It is the reason is that I have positioned it properly. See, always hand crank has to be below the oxygenator. Always. So the planning starts when you start ECMO. The planning starts when you start ECMO. Okay. If your hand crank is not here, if it is somewhere else, you cannot take hand crank, and you can't hold and run the not more than 2 minutes, isn't it? Am I right? You can't be able to do it for more than 2 minutes. It's heavy and it's going to be difficult. Okay. Plus there are a lot of tubes which might get kinked. Okay. So these are the difficulties which you face when you to do. So your position of the hand crank has to be something like this. Okay. It has to be below oxygenator so that immediately you can put the pump here and you can start. Second thing, you should have a free movement. You should always check the free movements. If this is too close to this, it will get stuck in the handles. Okay. So when you initiate ECMO, see to it and make it habit your staff that they should put a hand crank below the oxygenator and it should be freely moving, because these complications can occur anytime. Okay. So yes. Now once the ECMO is stopped, okay, as I told you, when ECMO is stopped means you are coming off ECMO, isn't it? So always put a clamp in the return line so that there is no backflow. Okay. And then you have to initiate flow. You have to use both of your hand. Okay. You can't do it with one hand. You have to use both your hand. You have to initiate flow to 1500, because when you initiate ECMO, we first increase the flow and then we release the clamp. Okay. You can't release the clamp first. So what happens most of the time, tomorrow what we are going to do, I am going to tell you. You are going to release the clamp and then start moving this. No, that is not the right way. You have to start moving this and then you have to release the clamp. Okay. So with the one hand, you have to keep on rotating. With one hand, you have to release the clamp. Again, this clamp is not that easy to release. It's not like your mosquito forceps. They are little harder than that. So it becomes little difficult. Fine. So these are the problems that you are going to face when you do power failure. And this has to be done ideally within 20 seconds. Ideally, it should be done within 20 seconds, max up to 30 seconds. Okay. If you take more than 30 seconds, you definitely require repetitions. And all of you, when you go from here, that you should be able to take the patient on hand crank within 30 seconds. That is what we desire, and that's the reason we will take your exams tomorrow. Okay. Individual exams tomorrow. Fine. The next is the component failure. So it can be pump failure, can be oxygenator failure, any of the component failure, and you require change. Okay. So first I'll discuss the component failure part and then I discuss change altogether. Okay. So what are the causes of pump failure? It can be because of your clot in the pump head, or if you have older generation like Medtronic pump, one of the bearing of the pump gets broken, so it can be because of that, or there's an excessive heat generation and that can cause pump failure. Okay. This I already discussed. Pump failure diagnosis, you can do it by the change in the RPM. With the same RPM, the flow decreases and the circuit pressures all decreases. On auscultation, you can get the crackling sounds, and there will be a hemolysis. Okay, so you will have a hematuria, you have a hemoglobin urea or Coca-Cola urine. All that will be the signs of pump failure. Okay. Management I'll discuss all together. Okay. Coming to oxygenator failure. So again, what are the causes of oxygenator failure? See, oxygenator failure can be pulmonary edema or what we call as a membrane edema. So what will happen is, see, whatever the oxygen is going through the gas phase, okay, this oxygen is cold, okay, so it gets condensated on the gas phase. So there is a small water molecule which are formed. Okay. So when these water molecules are formed, they remain in the gas phase and they will decrease the sweep gas. So even if your sweep gas you have kept it 4 liters, the actual sweep gas which is going through might be only 3 liters because the space is occupied by the water molecules. So that is what we call as a membrane edema. So what you need to do is every 4 hours you have to increase your sweep gas to more than 10 liters. So because of the increased sweep gas, because of pressure, the all water molecule which has got accumulated there, condensed there, will come out. Okay, and you will literally see from the exhaust of the gas line, the water molecule is dropping. Okay, and that is what we call as a sigh. So like the way you give a sigh ventilation, it's every 4 hours you have to do a membrane. You have to just blow out the condensated water. Okay, that is what is membrane edema. If the membrane edema persists, you will have a increase in the CO2 because the sweep gas what you have decided is not going actually, it is going less. So your CO2 will start going up. So and that you have to do every 4 hourly by default. Okay, so you have to instruct your staff every 4 hourly they have to do blowout. Okay. Second is the plasma leak, which you don't see in the polymethylene PMP oxygenator, you see only in the polypropylene oxygenator. Third is a vacuum mismatch. So some area of the oxygenator is ventilating well, some area will not be ventilating well and but perfusing well. So there can be a vacuum mismatch like what you see in ECMO. You can have massive embolism which goes to the oxygenator and can block the oxygenator completely. So you can have oxygenator embolism, or some of the gas fibers start degenerating and it becomes atelectatic fibers. So they don't do gas exchange. Okay. So pulmonary management, I already told you, you have to increase the sweep gas to more than 10 liters, okay, for 10 to 15 seconds only. Don't do it for more time, just for 10 to 15 seconds, and again come back to the same sweep gas levels, okay. Now, coming to the change of oxygenator or change of pump or change of circuits, all the three things are going to remain, more or less the steps are going to remain same. I'll just describe you first and then I'll ask my staff to demonstrate you. Okay. Now, whenever there is any of the component fails and when you need to change a component versus a circuit, okay, you have to understand that you are going to come off ECMO for some time, and that sometime might be 1 minute, or might be 5 minutes, or might be 15 minutes. We don't know. And again, at what stage of ECMO patient is and you are doing a change, it depends entirely on that. If the patient is ECMO dependent, believe me, he will not even give you 1.5 minutes. Why? The reason is because the native organ is not contributing at all. Okay, and patient is live on ECMO and you are stopping ECMO. So you are literally creating asphyxia, and that asphyxia does not last for 1 to 1.5 minutes. The patient starts going desaturation, bradycardia, even cardiac arrest. So those patients who are ECMO dependent, they can go into cardiac arrest within 1 to 1.5 minutes. If the patient, if you are not going to change the component, restart ECMO within 1 to 1.5 minutes. Okay, that is very important step you should remember. Okay. Now, before going to the change, what are the advantage or disadvantage of changing the component versus changing the entire circuit? What will you prefer? Component? Yeah, one is the cost. Okay. If you change the entire circuit, the cost is going to be huge. If you change the only component, the cost is going to be less. That is one thing. Fine. Second, time to change won't much of difference, because you have to take out from two sides and you have to connect it two sides. So probably time of change will not make a much of a difference. Asepsis, again, that won't be. Yes, if you change the entire circuit, the asepsis can be practiced well. If you change the only components, you might breach the asepsis. Okay, so that is component, but again, that is not the major component. SIRS, yes, somebody said that is an important thing. If you change the entire circuit, you are inviting another SIRS reaction. You are changing the 700 ml of volume in adults and 350 ml of volume in pediatrics. So you have to be mindful about that, because you are going to, so if hemoglobin is low, you have to do blood transfusions. Okay, your circuit is new circuit now. So again, there will be all sedative drugs, all drug gets adsorbed to the circuit again. Previous circuit was saturated now, so there is no more adsorption was taking place. Now again the new circuit, so these are the disadvantage of changing the entire circuit versus changing the components. Okay. But problem is that most of the companies, they don't provide you separate components, so you'll end up changing the entire circuit, but the cost goes up. Okay. Except you need to change oxygenator, you have a separate oxygenator as I told you, so you can change the oxygenator by that. Okay. So now, when you want to change, whatever you want to change, suppose when you want to change, what are the steps you are going to follow? Anybody? Okay. Before that, okay, okay, priming the circuits, all that part. But the first step is, see, first is you have to decide whether it's going to be an elective or it's going to be an emergency procedure. If it's a sudden big clot has come and stopped circuit completely, there's no option, you have to change it. There's no question of thinking of anything else. Okay, that's an emergency. It has to be, ideally, you should always try to get it becomes elective. So your monitoring is most important. Your P1, P2, P3 monitoring is going to be important. Okay. So now suppose that if it's an elective, okay. First thing is you have to divide yourself in 2 teams. Don't forget these basics. First thing is you divide yourself in 2 teams. One is going to manage the patient, one is going to manage the ECMO. Okay. Now what a person is going to do, who is going to manage the patient? Number 1, it will increase the ventilator settings. It will adjust the inotropic supports so that he knows that this patient is going to remain off ECMO for another minute or 2, and he has to manage the patient without ECMO for that much time. Okay. So it is going to be as if patient is not on ECMO and you have to manage the patient. So go up on ventilator, go up on inotropic supports. Okay. Keep all emergency drugs loaded and ready. Be ready for CPR. Okay. And these are the steps that person is going to do, is going to take it, and inform and take the consent from the relatives. These are the things who's the person who is going to manage the patient, he is going to do it. Okay. Many times lungs are very stiff, you are not able to ventilate them. So you might have to take the patient on bench. Okay. So that you might be able to ventilate to some extent. So take the patient on ambu bag or bench circuit and try to ventilate the patient. Okay. So these are the steps the patient management team is going to look into. Okay. Now, as against ECMO team, what he is going to do? He is going to prime the circuit or the component which needs to be changed. So he is going to organize that, start priming it with the crystalloids. Okay. If it is the entire circuit, you have to think about whether you want blood priming or only crystalloid primings. So again, that will remain as an initiation part. So if you require blood priming, prime with the crystalloid first and then do blood priming. Okay. That is the second part he is to do. Third, he is going to increase the sweep gas. Okay. Now why increase the sweep gas? Increase the sweep gas at least 1.5 times what it was basic. Why? See, always remember, all of you must have seen during COVID, it's hypoxia does not kill. Patient has come walking with saturation of 60, 70, so that is not going to kill you immediately. What is going to kill you is hypercarbia. So if the ECMO is stopped, the CO2 cannot be removed, CO2 builds up, there is a hypercapnia, and this hypercapnia leads to severe respiratory acidosis. The pH comes down to 6.7 or 6.8, and that leads basically the patient to go into cardiac arrest. So it's the hypercapnia and respiratory acidosis that is what is going to kill the patients. Okay. So that's why you can increase the sweep gas. Now increasing sweep gas will get the CO2 down. Okay. It was basically 40, it might get it down to 30 or 25. That might give you 2 to 10 seconds extra, nothing more than that, but it might give you some few seconds extra, so that if you take a little more time to change the oxygen, that might help you. Okay. So when you start priming, you go up on the ventilator settings, at the same time increase the sweep gas to 1.5 times. So that will able to manage you, might give you some more time for change of components. Okay. Now, another thing is, what you said is right. You need to find out the countdown time. Okay. So what you can do is, see, once you are going to change the circuit or components, you clamp and you cut it. You can't do anything. If patient goes in bradycardia, you can't do anything because we already cut it. Okay. So before doing that, you do a countdown. You find out the countdown time. So what you can do is, when the patient is on ECMO, just put the clamp on the return line. So ECMO is stopped. Monitor the saturation heart rate. The moment you see that heart rate which was 110 has come down to 80, 90, immediately release the clamp. And not that much time. It means your patient will give you 1 minute, 1.5 minutes, that much time to change the oxygenator. Now why this is important is, because if the patient is too sick, you will like to definitely have more expert people and more number of people who can do it. So you can have a 2 team, one can do a change of venous side, one can do change on the return side. Both teams can work together, so the time becomes almost half. Okay. If your patient is going to give you time for 2-3 minutes, then your one team is fine enough. But if if you see that time is not much, then you can plan accordingly. So that is again a most important part. Okay. Then when you need to change it, it is our double clamp method. That we are going to show you how to do double clamp method. You have to put 2 clamp before the components which you want to change. Suppose you want to change this, you have to put 2 clamp here, you have to put 2 clamp here, and then you have to cut the tube. Okay. So that is what we are going to change the components. Put 2 double clamp method, 2 tube before and 2 tube after. Remove it, take the new pump and connect it. Okay. So it will be 3 people at least we will be required to do this. Ashok. Okay. So we'll show you, demonstrate you how to do it. Okay. उड़ा लो उसको. चेंज करना है ना. ओके. हाँ पहले पंप चेंज करना सीखा. जस्ट पोजीशन दीजिए એટલે they can see. Now suppose we want to change the pump, so this pump is primed and kept ready. So you can see this pump is primed. Now, okay, and it's kept it ready. Okay. Now, when you are changing it, changing the components, okay, or changing the circuit, you to see, it's an electric procedure, so you have to plan everything. So it is, you require 3 people to do it. Okay. Now you have to plan everything from where you are going to cut it. Okay. When you are going to, from where you are going to cut it. Whether you are going to cut it from connector. So whether you are going to preserve the connector or you are going to lose the connector. That is what you have to decide. Okay. You cannot connect tube to tube. You require one connector in between. So that is what is most important is. Suppose you connect, you don't keep the connector and there is no connector here, there is no connector there, then you will have it. Okay. So it is essential that you should plan first. So always you should plan, yes. Now I am going to use connectors in both the sides. So I primed it with the connectors. Okay. Now this is going to be a venous end. Okay. This is going to be a return end. So I know this is going to be connected like here. So either here or here, wherever. But I'm not going to use connector from this. I'm going to use connector from here. And this is going to get connected here. Okay. So that I know. Now there are 3 people will require. One is going to hold this pump. Okay. One is going to be holding this pump. One is going to put the clamp on the venous side. One is going to put the clamp on the arterial side, and they are going to cut the tube. The moment they cut it, this pump has to go out and this pump is going to be built in. Okay. So we'll show you how we are going to do it. Okay. Before that, a team leader has to instruct everybody that what they are going to do it. So यहाँ से काट दे. Okay. यहाँ पे claim कर काट दे. यहाँ पे claim करके काट दे. Okay. So let them put 2 clamps here. Yeah. Yeah. Cut. Okay. Now when they are cutting, the pump speed should come down to 0. This person is going to remove this pump. Yeah. Okay. You are going to remove the pump. Once the pump is stopped, you are going to remove the pump. Put a new pump on this. Okay. Now this end has been okay. Both ends are being cut. Okay. This is an old pump which goes out. This is a new pump. Okay. Okay. Again it has to go without any air. Now it is important that how you are holding the tubes together so that there is no air that comes. Okay, that is important step that you should remember. Okay, fine. Then always when you are starting, open the venous clamp first and the last the return line clamp after initiating the pump. Okay, fine. That is what for the pump. Oxidator change, again steps remains the same. Only thing is that you don't have to come out of the, you don't have to come down to zero flow. You don't have to remove the pump because you are changing oxidator, not the pump. Okay. So when you want to change the oxidator, again the steps remain same. They'll show you how to do it. Okay. So you want to change this oxidator. You don't require to come down on flow. Just put the clamp. You are going to remove it from here. So put the clamp here. Okay. So this is pre-oxidator. This is post-oxidator. So put the clamp here. Okay. Two places you put the clamp. You cut the tube in between the clamp and then connect again. Okay. So fine. Yeah. Yes, अभी करना है. नहीं वो कनेक्टर लगा दे. Clamp them. Okay. So I am going to put the clamp here. Okay. Yes. Okay. So we are going to cut it from here. I am going to put a clamp here. I am going to put a clamp here. वहाँ पे दो clamp लगा दे. Okay. वो वहाँ से बीच में से काटने का. Yes. Yes. Now. So put a clamp. Clamp. Okay. First clamp the arterial line, return line, then the venous line. Okay. Cut it fast, chalo. Okay. Okay. This has been cut. This has been cut. Okay. Put NS. See the angle of the hand and the tube how they have been kept, so that there is no air. Okay. First remove the venous clamp and then arterial clamp. Yes. Yeah. And once you do, connect the gas phase also. Okay. Because if you don't forget to connect the gas phase, you are just moving the blood without doing any oxygenation. It is like sweep gas is zero. Okay. And when you do it, you have to see that there is no air, there is no clot. Okay. That remains in this. Okay. Now again, it looks very simple when you are doing it. But when you do it by yourself, you find there are a lot of difficulties. Now, what are the problems that you can face? What are the problems that you can face is, as I told you, first is, you might see that you have cut the connectors and you are finally landed with the two tubes opposing each other. So you can't connect it. And then you search for the connectors and then that much time is going to be wasted. See here, the time is the most important thing. Okay. Second thing is, you cut the oxidator or cut the components, the tube length you have not kept the same. Then you are struggling. The pump is there, your oxidator is here, and you are trying to match, so you are struggling. So you have to see to it that you measure the tube length when you are cutting it, so that you cut it properly. Okay. So that is the third thing. Second point. Third point is, you do it a reverse connection. When what do you mean by reverse connection? You connect the drainage line to return line and return line to drainage line. Now this can happen because you are in emergency. Okay. The patient is going crashing, patient is hypotension, your medical team says that you do it fast, patient is going to bradycardia, so you are in tensed up. So in that case you can connect it wrongly. So now everyone should know the role. So the person who is holding this oxygenator, the person who is holding the pump, it is his responsibility because he is free. His mind is not occupied. The two persons who are changing, their mind is occupied. They know isko cut karne ka, isko lagana hai. So their mind is occupied. So they know they have to cut it and attach it. But this person who is sitting with the pump, his mind is free. So he will know that yes, he will give venous line to the person who is holding with the venous line and arterial line to the person who is holding with the arterial line. That is most important steps you should know. Okay. Anyway, we are going to do all this tomorrow when we are going to discuss. Okay. The next is a blood cannula. Okay. Now, blood cannula is going to be, and extended decanulation is going to be a nightmare. So you can suddenly see that there's total stoppage of flow. There's no flow going on. So how will you see whether it's a blocked cannula, it's a blocked oxygenator or blocked circuit? See, yes, if your delta pressure is increased, okay, then it's going to be your oxygenator failure. If your both P2, P3 is increased, it means there is something wrong after the oxygenator. Okay, so it can be a cannula blocked or after the oxygenator which has got blocked. Okay, that is one way. Second way of confirming it, if there is a circuit in the uh, if there's a bridge in the circuit, you can clamp the cannula and rotate them and start, circuit. If circuit starts moving, it means there's nothing wrong in the circuit. The blocked is the cannula blocked. Okay. So there are the two ways you can diagnose cannula blocked. Okay. Now how will you manage blocked cannula? See, when you have blocked cannula, you are going to face few problems. One is suddenly your ECMO is out. So you have to manage the patients to without ECMO. Okay. So again, this is ECMO related complications. Divide yourself in two teams. One will look after the patient, one will look after the ECMO. Okay. So the one will look after the patient. Again, he is going to go back on the high ventilator settings, high inotropic supports, and trying to manage the patients. One who is going to look after the ECMO. What is his duty? This blocked cannula, he has to take this blocked cannula out, number one. Number two, he has to maintain the circuit. Otherwise, you have to use a new circuit. So he has to put a connector, 3-bind connector, connect both artery and venous line and let the circuit recirculate. Okay, so he has to manage the circuit patency. So first thing, he has to think about taking this cannula out. Okay. Second thing, he has to do a recirculation in the circuit so the circuit does not get clogged. So recirculate the circuit, that is the second thing he needs to do. Third, anyone? Okay. Put another cannula, fine. Yes, remove that cannula, put another cannula, okay, fine. Then, what else? Hematoma. Before that, more important. Yeah, but that all comes later on. What is more important? The one cannula is still preserved. If that cannula remains without moving, okay, that cannula gets clogged. Okay, so you have to see to it that the next, the one cannula which is remained, which is preserved, you have to maintain the patency of that cannula. So what you need to do is, you need to do heparin flush. Okay, so you can connect that cannula to the heparin portal and also to the prime set and keep on let the heparin solution go through that cannula continuously so that cannula remains patent. If it is a arterial cannula which is patent, then you have to put a pressure bag and give cannula, give the heparin saline to the pressure bag. If it is a venous, you can just connect it from the gravity, it will go. Okay, so three things he has to do. One, he has to take care of circuit so that circuit does not get clogged. He has to take care of the cannula which is preserved, that does not get clogged. And third is, blocked cannula is already blocked, so you are not worried about whatever damage has to occur, it has already occurred. Okay. Then you have to take the decision whether this patient can be taken off ECMO or he still needs ECMO. If you feel that this patient is borderline improved, you can manage them with little higher ventilator supports, you might get rid of ECMO and accept the higher ventilator settings. If you feel now this patient is not going to manage, then you have to put again the cannula. So you have to take out this cannula and you have to put another cannula. So you have to arrange for the one who can put the cannula also. Okay. These are about the accidental blocked cannulas. Okay. How he is going to manage the accidental blocked cannula. Okay. Again, it is important whether it's a venous cannula which is blocked or arterial cannula or return cannula which is blocked. If it is venous cannula is blocked, you are still little less worried, but then the risk of a pulmonary embolism is there. If it is an arterial cannula which is blocked, then there is a risk that the clot might have gone down and it might cause to peripheral emboli, systemic emboli. So you have to take care of systemic emboli also. So when you remove that cannula, you have to do Fogarty and remove all whatever the clots are there, so that you can take care of the limb also. So that is about the management of blocked cannulas. Okay, always go for the root cause. What has caused this? Okay, it was because when there is a blocked cannula, it means, or anything which is thrombotic, it means your ACT is not adequate and you have to keep higher ACT. So that always thing you have to keep in mind so that it does not repeat. Okay. Another drastic thing like block cannula is your accidental decannulation. Okay. So one of the cannula comes out. Again, problem is more or rather worse. Because once the cannula comes out, okay, if it is a venous cannula, it will suck the air because it's negative pressure. So the air goes and gets filled in the circuit. And you have to remove the de-air the circuit entirely. Okay. And the machine definitely ECMO stops. That is for sure. Okay. If it's a return cannula, you have to immediately put the clamp, otherwise patient is going to lose lot of blood. Okay. Your pump speed is 3 liters per minute or 4 liters per minute. Okay. So the moment the patient, the return cannula comes out, he is going to extinguish with the blood. You know, a lot of blood comes out, 500 ml, 1 liter of blood, and the patient immediately collapses. Okay. So that's going to be a dreaded situation if the accidental decannulation, the return cannula is there, because it's going to be coming out with the force. Okay. So management wise, you have to immediately clamp, whether it's a venous cannula or arterial cannula. Take somebody, again divide yourself in 2 patient as well as ECMO. ECMO team will take care of circuit. Okay. The patient management team is going to take care of the cannula which has come out, so you have to give pressure and stop bleeding. Okay. If it's the venous cannula, again you don't require to give much of a pressure. Even mild pressure is enough, you will be able to control the bleed. If it's the arterial cannula which is 17 French, 19 French comes out, you are going to have a hell of the time to stop bleeding. Okay. Immediately arrange for a surgeon to repair the vessels, because that vessel which has got a big vent, so you have to repair this vessel so that blood doesn't come. Okay, bleeding stops. So that is what you require to do it for a if there is an arterial cannula has come out. Rest of the management remains the same as of your accidental decannulation. So you have to take care of circuit, you have to take care of the another cannula which is patent, decide whether the patient needs ECMO or doesn't need ECMO. If it needs ECMO, again put another cannula from other side. So all that steps remains same. Is this clear? So that's about the accidental decannulation. I know I'm going a bit fast, but I think it's too late also so for you people. So, okay. So this is about the accidental decannulation management, how you are going to manage. These all steps are written in the book, so you don't have to worry about this. Everything is given. You have got enough time today. You can read the book. Also, whatever the delegates evaluation sheet is given. No, they can read only the mechanical complication part, or they can read the delegate performance form. So all crystal steps are being given there, so you can read and come. So that becomes easier for you to perform tomorrow. Okay. So that is about the accidental decannulation. And the last part is heat exchanger failure. I think that's probably the simplest but difficult to diagnose. The reason is if you are not monitoring temperature, it's going to be difficult to diagnose it. Okay. If the machine fails or not working, then you can have a hypothermia, or if it malfunction, you can have a hyperthermia. It can occur in anything, hypothermia or hyperthermia. So you might get the signs of hypothermia. So your saturation suddenly starts improving. You are very happy. Your saturation is good. It's not always good. Okay. It might be just a hypothermia which is increasing your saturation. You can have bradycardia. You can have arrhythmia. You have coagulopathy. Your acidity goes high. Suddenly, patient shows appetite is high. All because of the hypothermic coagulopathy. Okay. The treatment is going to be change the your heat exchanger. That's what you need to do it. Okay, and control the temperature. I think that's it. Yes. See, all oxygenator has got a heat exchanger fibers inside. So from here, if you see, tomorrow I'll show you the cut section of these fibers. All they have got a heat exchanger. This has got a 2 types of fibers. One is an PMP fibers which carries the oxygen, and second is your polycarbonate fibers through which the water is passing. Okay, and that water which is passing is the warm water which comes from the heater unit. Okay. Any questions regarding mechanical complications? Okay. Yes.